part one of a two-part series talking about older adult care. I'm Ginny Flynn, Vice President of Communications at the Academy, and I'm going to get us started with just a few quick notes, and then we will get right to our presentation. We've got a great panel for today. Here we go. The Geriatrics MIG is open to all IAFP members. You can find it under the membership tab. Just log into your profile, go under My Features, and activate the eList for Geriatrics. There are lots of resources on the MIG's webpage, and I'll send lots of great links and follow-up information in an email after this event. It's important to recognize our commitment to diversity, equity, and inclusion. We support it in all its forms, recognizing that these require an enduring commitment that must find full expression in our organizational culture, values, activities, and behaviors. And we hope tonight's event exemplifies that commitment. Just a quick set of the typical Zoom etiquette reminders. Make sure you are on mute. Keep your camera off or on, but just be aware of your surroundings. You can pose questions to the attendees in the chat. You can answer questions, you can pose questions, you can ask questions of the panel in the chat. And if time permits, we'll even be able to unmute and have some discussion. All the slides and resources will be emailed to you along with the link to the recording, most likely tomorrow to get time to process. And then we have a great lineup of 5 people. We're going to start off with our leadership, Dr. Lucas Ranjit, who's the chair of the member interest group and on our the Illinois Academy of Family Physicians Board of Directors, and also Dr. Avinash Mehta, another IAFP board member who works for the VA Medical Center. We have IAFP President Emma Daisy. Dr. Emma Daisy completed a geriatrics fellowship and is now using a lot of that training in her everyday practice. And Dr. Priyanka Bandari from SIU Springfield, again, who is incorporating the care of older adults into her family medicine practice. And then batting cleanup for us is Dr. Vivette Orgain, IAFP past president, NMA past president, and our subject matter expert on a lot of things regarding health equity. We'll bring this conversation home discussing some of the health equity and bias issues that are prevalent in the care of older adults. That being said, I'm going to go with just 2 quick poll questions and then turn it over to Dr. Ranjit to get us started. So first, our poll questions. Hopefully you're seeing that on your screen, so you can tell us where you are in your career, and I can see the answers starting to jump very quickly. We'll give just another couple seconds. All right, so who do we have on here today? Okay, and hopefully you're seeing the results that we have quite a few experienced physicians here, some early to practice, early careers, and some medical students. Okay, and then our second one is here we go. We want to hear about your knowledge or your current knowledge level with respect to geriatric care. All right, I'm going to close the poll, share the results with everyone. Unfortunately, no one said 0 training, so that's a good start to our discussion. All right, with that being said, I'm going to stop sharing the poll and turn it over to Dr. Yukesh Ranjit to get us going.
Hi, everyone. Can you hear me well? Okay. My name is Yukesh Ranjit. I am a geriatrician located in Springfield. I am the director of Geriatric and Palliative Division here under Center for Family Medicine in Springfield. And a few years back, me and a few of other family physicians, including Raj Shah, who's here with us today, we started the geriatrics member interest group within Illinois Academy of Family Physicians just to focus on the issues that we have with geriatrics and aging and an aging population. As all of us know, we have a population that is aging, the wonders of medicine that we have, screening, immunization, treatment of many conditions that were not possible even 10 years ago has led to more and more people living longer. When it comes to Illinois, currently, there are about 2.7 million people who are over the age of 60, and they make up about 21.9% of our patient population. The population is expected to rise, and by the year 2030, 22.3% of our population is supposed to be over the age of 60. It is a good thing, I would say, that people are living longer. And we are in a new frontier of medicine right now where we had never been before, basically. The wonders of medicine, it's working, basically. And in this new frontier, we have new challenges and new, problems that we're facing and new opportunities that we have to move medicine even further. Primary care providers, family physicians, we play a key role in that, especially in a state like Illinois, where according to the last number that I checked, we just have 227 geriatrics trained physicians. Down here in central and southern Illinois, where I work, we often joke out of the 227 geriatricians, 220 are in Chicago and 7 are down here scattered throughout the state. With that kind of patient population, a huge chunk of what geriatricians do, just because of the scarcity of geriatricians, will end up being done by primary care providers. And for this reason, I think we should know more about geriatrics. And in doing so, we were just trying to create some programs whereby we could talk and interact more about issues related to geriatrics and aging. Today, we'll be talking primarily focused on the 5 M's of geriatrics. It's one of the ways of summarizing, different things that happen to people as we age and ways to, manage those 5 M's. I could go on talking on and on about those 5 M's, I could take the whole hour, but I would just like to briefly touch the first 3 M's of the 5 M's. And Ginny, if you could pull up the slide for 5 M's. So, the slide. So 5M is an acronym. It's a way to remember, some of the most common things that happen to people as we age. Some of the things that change for people as we age is that there's a change in our mind. Within the mind, we tend to talk about 3 Ds the most: dementia, depression, and delirium. And there's obviously change in mentation as well. Dementia has been a topic which has been in the news a lot recently with some of the medications being developed, and there's a question of whether we should be detecting dementia early on as well. We don't have really great answers for that, and we would like to have more interactions whereby, primary care providers would know more about how to handle such situations. Delirium is something that we oftentimes see, especially in inpatient settings, where patients, older patients in the hospital away from their natural environments tend to have more confusional states, and it carries a very bad prognosis, both for their morbidity and mortality. The hospitalization, the days that the patients spend in hospital is prolonged if they develop delirium. And there are ways in which we can reduce the risk of delirium. Depression is something that has become more common, especially after the COVID pandemic we've had, where loneliness has increased and more older people are living by themselves. The social interaction has decreased as well, primarily because of the COVID, flu, and RSV infection that is going on. A lot of older people do not go out and socialize as much as they used to. One thing I would like to say about depression over here is that not all older people, they talk about feeling depressed. A lot of times they just talk about feeling a loss of energy, and screening for depression would always be a good idea for older population. Functional impairment, activities of daily living, and a change in gait and balance they formulate the mobility part. Fall is an important event that happens in older adults. Fall carries a heavy mortality, and a loss of functionality. So screening for falls and making sure that we implement fall preventive measures for older patients would be helpful for older population as well. And the third M that I would like to talk a little bit about is multi-complexity, basically. Older patients, they have a number of chronic medical conditions, advanced illnesses, and their needs are different. I remember reading an article, I think it was by Dr. Cynthia Boyd in JAMA, that was published a few years back, where they created a patient, a simulated patient rather, who had 6 of the most common, if my memory serves right, medical illnesses in the United States, and they went about with guideline-based therapy for all those 6 diseases. The patient, if I remember it right, had to comply with 18 tasks every day, and they had to do a certain number of tasks every month, other tasks every 3 months, other tasks every 6 months, and other tasks every year. So there was like about, I think, somewhere around 20 to 30 tasks that the patients were supposed to do. An average American person is a high school graduate, and we expect a high school graduate to know about all of these complex mechanisms and somehow comply with all of our instructions. It's a battle that is always hard, and basically a battle where we seldom have the best outcomes. And just talking about ways to mitigate some of the problems we face in multi-complexity would help primary care providers significantly, I would presume. I'd just like to end my talk for now right over here. I would not like to bore all of you with my ongoing rambling, and I would like to call upon Dr. Mantha to introduce yourself briefly, and then just to continue with the remaining 2 M's.
Sure. Yeah, I'm Avinash Mantha. I'm a geriatrician, so I completed my FM residency, which was about 6 years ago. I then did a geriatric fellowship at Loyola Medical Center through the Edward Hines VA Hospital out in Maywood. And I was in private practice for about 1.5 years, and then I returned to the VA, where I am associate program director of our geriatric fellowship, where I have a mixed practice, where I do home visits mostly, actually, but I also have an outpatient clinic where I precept and I teach fellows and residents and medical students, and I also do some inpatient work and some nursing home work as well. So I'm going to basically touch on the last 2 M's here. So we have medications. And I think that this has been a big focus recently over the last few years. I even hear a lot of our trainees, our students and our residents, when they're rotating through the clinic, when I ask them, what they want to get out of a geriatric rotation, they almost always mention polypharmacy, and the idea that our elders are on a lot of medications. At times, 5, 10, 15, 20 medications in some cases is not uncommon, right? So we want to use every geriatric visit and each visit with these patients as an opportunity to really carefully go through their medication list and assess for the risks and the benefits of all their medications. There are some, medications that are, of course, very sort of geriatric unfriendly medications. If you have heard of the Beers list, which is, famous, has been out now for some time and was just recently updated. And of course, those, medications would be the anticholinergic medications that would increase, fall risk a lot, would increase risk of confusion, first generation antihistamines, Benadryl, our tricyclic antidepressants, things like amitriptyline, oxybutynin, which we have used for overactive bladder, which we tried also can be anticholinergic as well. And looking at if the patient is on benzodiazepines or is on narcotics, do we have an opportunity to perhaps offer them a taper if they have been on it for a long period of time? Can we, of course, use other sorts of modalities to treat pain and anxiety, because you don't ever want to sort of take away something without actually having something else to offer to a patient, right? So we want to, be able to offer them other modalities to be able to, treat their pain and anxiety. And of course, if they have overly controlled diabetes, where they're having low blood sugars, or if they are hypotensive, where they're having, low blood pressures, or they're orthostatic and they're falling and they're dizzy, then of course that would be another opportunity to reduce medications and to be, taking away some of the medications that they're on for the diabetes or their hypertension. But also too, I would add, lots of times our elders are not given appropriate medications either, which is the other part of ageism, right? So at times they actually should be on aspirin or a statin or be on anticoagulation, for their AFib, and they're not. And the reason is, well, they're old, so that isn't a, like an actual reason, right? To actually go out to deny a patient appropriate treatment for a condition just off the basis of age. So it's important to always look at risk and benefit for every medication that we prescribe. And the last M would, I think, is, sort of really the, heart of geriatrics is what matters most. And I think that we at times think about this from the very sort of, hospital focused care, right? Is a patient full code, or are they DNR, right? Do they, what do they want to do when their heart stops? Or about the LST notes about feeding tubes and about dialysis and about, BiPAP, or about other kinds of invasive interventions. But also, I do a lot of home visits. And so I have patients who, of course, because they are homebound, they are precarious at home. They are, falling a lot. They need to have assistance, like with multiple ADLs. And these are people who, frankly, who we would advise higher level of care for. But these patients are intact cognitively, and their wish is to be at home. And they understand, what that means, and they understand the risk, but their goal is to be at home. And so, like, a lot of what matters most is about, what the patients and preferences are, where they would like to have their care delivered, how much that they would like to have done, how much of a workup do they want at the age of 90 if they have weight loss, right? Are we going through the EGD and the colonoscopy and the CAT scans, right? So all of this is important in the context of that. I'm also going to sort of do a transition here, where I'm going to talk about geriatric fellowships a bit, and what they are, and why I think it is a benefit. So yeah, so I'm going to just pull up here just a few slides. Okay, so everyone, I think, can hopefully see that. So basically, what is a geriatric fellowship? It's a 1-year training program generally. They actually used to be 2 years in the old days. There was a research year that was added on to it. And it is designed for the care of the elderly, right? To become an expert in this care. And it's usually done after completion of a residency program that's in family medicine or in internal medicine. So for any students out there sort of, thinking about like their futures and, what that would be. So our fellows rotate through various training sites, which would include nursing homes, outpatient clinics, inpatient geriatric units. There also is a palliative care consultation service as well as an inpatient hospice unit. So the idea is that our trainees would get a wide sort of breadth and depth of exposure to all that we would offer in a geriatrics training and all the sorts of patients that they would see. And the idea is that we want our fellows to be experts, right, in these sort of geriatric topics. So in these 3Ds, as Dr. Ranjit mentioned, right? So dementia, delirium, and depression, certainly in the elderly, osteoporosis, right? We also do have a lot of focus about functional status and about fall prevention and about rehab, because a lot of that is at the heart of geriatric medicine, about ADLs and about IADLs, what the patients are actually able to be doing for themselves. And we also do have a robust goals of care training, so our fellows rotate through inpatient hospice and also outpatient palliative care. And we expect that at the end of their fellowship that they'll be experts in that, and that will be something that will come easily to them, and that they would not, have to be asking a palliative care consultation to do those sorts of conversations. And we're looking at the 5 M's model with each patient, right? So in brief, right? So that's the sort of, heart of geriatric medicine, is that sort of, 5 M's model. So why do a geriatric fellowship? Actually, so if you look at data and about surveys, actually geriatricians report some of the highest job satisfaction of any field of medicine. It's a field that is rewarding, and a geriatric fellowship will actually help you in any field of medicine, right? So in a traditional outpatient family practice, most of your patients will be elderly, and a mastery of geriatrics will help you to be better at your job and will help you to be a better family doctor. On the other hand, most patients who are in the hospital are also elderly, right? So that geriatrics training can actually help you to coordinate safe discharges, right? To do goals of care conversations, and to also sort of do that basic sort of functional assessment about rehab and understand social and the physical needs of the elderly. And you can also work with a underserved population, right, who appreciates the effort. And so I will say this all the time, but patients who are in their 80s and their 90s, they appreciate what I do. They appreciate a person who's able to actually spend time with them and explain all of their medical problems to them, someone who can be their advocate, and to be an expert in your field, right? There are not a whole lot of geriatricians. So if you have geriatric training, you will be an expert in the field. And so we've had graduates go almost everywhere. We've had them go to outpatient family practice, outpatient internal medicine practices. Of course, I advocate for FM, as I'm FM trained, as we all are. And as nursing home physicians, right? So we have people go on to become medical directors. There is a leadership track that we do have in our fellowship, and also as a hospitalist, which may at first be a little bit, I guess difficult to understand, but that so my geriatric training helps them to be a better hospitalist and to understand the needs of a hospitalized patient, and to understand delirium and how to diagnose it, and prevention strategies for delirium and all those things. And we've also have had some graduates go on to other fellowships. In fact, they have gone on to do things like cardiology or pulmonary ICU, and they have reported that having geriatric training has actually helped them in those fields. And I would add that in the VA system, this has been recent. I know, of course, that there is naturally is a talk about compensation, but that actually geriatricians are compensated as a specialist. So that has been a recent change, and I hope that that's something that other health systems will adopt in the future. And just to end with just a bit about the VA, we're located at the Edward Hines VA Hospital, which is next to Loyola Medical Center in Maywood, which is in the western suburbs of Chicago. It's about 3/4 at the Hines VA and about 1/4 at Loyola. So the VA is the largest educator of medical trainees. Over 80% of students and residents rotate through a VA at some point in their career. So almost anyone who is actually trained anywhere has been at a VA at some point in their career. And so understood the importance of geriatric medicine in the 1960s and the 1970s as those, as those veterans who were in the world wars, World War I, World War II, became older, they understood that it was important to have geriatric medicine as its own field and to have research in geriatrics. And actually, a lot of the very good geriatric research first came from the VA. And it's a collaborative care model, which is unmatched. I'm able to work closely with a pharmacist on my patient panel, with a psychiatrist, geriatric psychiatrist, social worker, dietitian, physical therapist. So it's really that sort of patient-centered medical home model. And with that, I'm going to actually turn over to Dr. Emma Daisy. She is our IAFP president this year, also completed a geriatric fellowship, and does outpatient medicine at a FQHC. So just wanted her to just sort of talk about what made her choose a geriatric fellowship and how she has applied geriatrics training into her everyday practice.
Thanks, Dr. Mantha. So my name's Emma Daisy, and I trained in one of the first teaching health centers here in Illinois, and then went on to do a geriatric fellowship at the University of Chicago. And like Dr. Ranjit and Dr. Mantha said, I think everybody should be a good geriatrician. I think Dr. Lofthouse had put something about that in the chat as well, that eventually, and especially as physicians maintain a panel and your patients age, you become more of a geriatrician, right? Because everybody ends up at the end of their life at some point. And working in the FQHC, we were seeing a lot of younger patients. And then in our inpatient setting, we were seeing obviously a lot more of the older patients. And I just felt like the FQHC was such a good medical home model for, community-based medicine, taking care of our patients. I think that's family medicine in general, but especially at an FQHC, I really felt like that was an important piece for taking care of our older patients, to keep them within their community health center and within their community, since for so many, staying independent or within your community or within your home is a goal of care. So with that in mind, and kind of thinking that I'd stay in that type of environment, I wanted to do a geriatric fellowship. And it was a great opportunity to get a jump start on that, because so Dr. Lofthouse's question was, how does the breadth of experience that you get with the longevity of your career compare with the academic training that you get in a geriatrics fellowship? And I think it's really hard to compare the two, because they're both really important, right? I mean, the academic training really gives you some of the specifics of geriatric care, and things like the 5 M's that they've been talking about. But a lot of that experiential education about multimorbidity, you're going to get, of course, through the breadth of your career, and the experience is going to be helpful. And I do think that many of the family physicians that I work with now, especially those that have been in practice longer, are practicing excellent geriatric medicine. I don't think you have to do a fellowship to do it. And I think the goal is for everyone to be a good geriatrician, which is why internal medicine and family physicians in residency have to do geriatrics as part of their rotations. But it did. I do think that the fellowship did help me in the health center, because it gave me the ability to feel like I am a specialist with geriatric training in helping those patients. So I can take referrals from other doctors in my clinic, or nurse practitioners, PAs. I can take referrals about complex patients. Sometimes it's just the time for evaluation. So because, and I'm lucky that my my employer, my FQHC, does sort of consider me as a specialist in that regard, that I can get a little bit of extra time when I'm doing those evaluations. So sometimes it's just for time, that if I can do a memory evaluation and get 30 minutes instead of 15, I don't know how anyone could do it in 15. It takes longer than that. So I get those referrals just for that, to be able to say, hey, Dr. Daisy is going to do just your memory. That's all you're going to talk about, and she's going to take extra time to do it. And then I can spend a little bit of extra time with patients. But honestly, the multimorbidity and the polypharmacy are things that I encounter with all of my patients every day. And I would like to be doing more of that as consults, because I think that also takes extra time and can be really challenging in an average clinic visit. I mean, you chip away at it little by little, but it's hard to really go through the whole picture, which sometimes you just have to do. You just have to say, okay, today's visit, all we're going to do is try to figure out which of these medicines you really shouldn't be on anymore. Does that, Dr. Mantha, were there other things that you wanted me to address?
No, I think that was very good. And you sort of even touched on it too, right? Of course, I think you and I, having completed geriatric fellowships, it of course is ideal and great if we could actually have that extra year. But I think teaching sort of geriatric principles like to residents and the medical students, and about how do you do like a geriatric assessment, that would be great, right? If we could sort of make sure that all those sort of trainees have that training, and if they feel sort of comfortable with the sort of basic principles of geriatrics, that would be something great too.
I think for specialists too, I was at the University of Chicago for my fellowship, and so there was, for example, there was an oncologist who had done the geriatrics training. There was another, hemonc, but he was doing more hematology, who had done it, and they're both amazing doctors, and they're both that much better now because so many of those patients are right. There's so many jokes about oncologists missing the boat with geriatrics patients, and to have someone who really understood that goals of care and that how to talk to the oncology patients about end of life decisions was so valuable.
Someone who understood that, hey, that patient who is bedbound and not eating maybe need to sort of back off a bit, right? And to not only be able to, and not only push further treatment, right? I need to sort of back off a bit and sort of look at the whole patient, right? Which is what we of course want to do in geriatrics, right? So we want to look at that whole person. So yeah, that's really important.
Absolutely. And if I may just chime in, I think this is about looking at the patient as a whole person, and also for that reason, I feel like family physicians are in a great position where they could do excellent geriatrics, because we take care of patients as a whole. We're not just focused on a certain system, not just focused on certain organs. But we take care of patients, and we see patients from birth, till they're old, and all those transitions. Sometimes knowing about pediatrics helps a little bit about understanding geriatric patients as well. I think our training helps us in that regard as well. So far we have been talking from geriatrician's perspective. Basically, Dr. Daisy, Dr. Mantha, and I are all geriatricians and family physicians. I wanted this webinar of ours to be not just about geriatricians, but about family physicians. overall. One of the prominent family physicians who is very interested in geriatrics in Central Illinois is Dr. Priyanka Bhandari. She is an assistant professor at Southern Illinois University, and she is currently working at SIU Center for Family Medicine. I would like for her to introduce herself and just enlighten us with some of her experiences and some of the pearls that you'd like to share with regards to taking care of older patients.
Thank you so much, Dr. Ranjit. Like Dr. Ranjit said, I am a family physician. I work at the SIU Center for Family Medicine in Springfield. It's an FQHC, and I also have the opportunity of teaching medical students and other students, the PA students, as well as our residents. So my perspective would be, I'm not formally trained in geriatrics, like I'm not fellowship trained, but I have always been, very, very interested in care of our geriatric population, because like all of you mentioned, and we as all know, that a huge population of, everyday patients that we see in our primary care, whether it's internal medicine or family medicine, outpatient care, or as hospitalists, is focused on our geriatric population. And as years go by, like Dr. Ranjit said, as medicine advances, the lifespan of people are increasing, which is good. So as providers, I think I would say in any field of medicine at this point and in upcoming years, we have to have that kind of, training, formal or informal, and incorporate those principles for geriatric care in our day-to-day practice. And I think this is what has been my biggest focus of trying to bring this up with our medical students and our residents, to make sure they have that understanding that, how am I going to take care of that geriatric patient? What are the principles I need to keep in the back of mind when I'm prescribing a medication to that patient? And like you all said, sometimes you have to take a step back and look at the whole picture. You have to look at the whole patient. We do that all the time in the primary care, but especially with the geriatric, patient, we always have to sometimes, take a step back and see what is their goals and what, there is no conflict of what we are doing versus what the patient desires. And then, from a family physician point of view, I see that a lot of times, our traditional geriatric training is very focused on the very important aspects, like you all discussed about the 3Ds, fall prevention, other goals of care. But then there's some aspects of our geriatric population sometimes which need a lot of focus as well. Maybe a lot of times the patients are just not bringing those up. Like and I don't know, maybe a little bias comes from my end because I was OBGYN trained back home in India. So I sometimes feel like, our female population who's in the geriatric age group, there is a lot of, I would say, need of training, understanding of our postmenopausal issues. A lot of this time when the patient will not endorse that, patients could be, suffering from incontinence for years and years, and just because, they're shy and they don't want to talk about it, unless you bring that up with your female, patient, she's not going to talk to you about it. There could be problems with vaginal atrophy, other issues, very, dedicated to our female, geriatric population, which sometimes just get missed just because we haven't had that amount of time, or, taken that step back to see, okay, maybe there is something more that needs to be addressed to the patient, or just because, we have not had whether formal or informal training on those aspects. And then, like this is one of the, those fields of, I think, geriatric care, which besides everything else, needs to have more focus. Our trainees need to be more aware or cognizant of these issues. Then we have, concern like we run our gender equity clinic, which is focused to care of our gender minority. And unfortunately, there is a lot of work that needs to be done for our geriatric population, in our gender minority, geriatric care in our gender minority population. As such, this population has not had access to primary care for various reasons, and I don't want to delve into those specific reasons. But I think as a family physician or as a primary care physician, you are going to see these patients in your patient care or your inpatient care or a hybrid care model, whichever you choose to go in later in life. And you need to have that training to take care of these patients and their specific concerns that come up in the day-to-day, care that you're providing. And then just touching on those, populations that sometimes get missed is our immigrant population, patients who have no insurance or are underinsured. A lot of times their health or primary care has been neglected over years, or if they have had a very hard time, finding a way through the complex or complicated healthcare system we have here. So if you are in the primary care office, you are going to see these patients every day. So you need to have that kind of, training or understanding, whether it is through a fellowship or through your extra training that you have to take care of these populations. And I think whether as physicians, whether we are in an academic or in a non-academic field, and we do have that duty to do that extra work to take care of this our aging population, to provide them the resources, whether these are medical resources or their help with their social resources or other avenues that can help them lead a better life, whether within their houses or outside in the in the nursing homes. So I think, like Yukesh earlier said, out of the 227 geriatric trained our physicians back here in Illinois, 220 are in Chicago. So the only 7 that are in Southern Illinois, they can't take care of the entire our ever-aging geriatric population down here. So all of the family physicians, our internal medicine providers who are in primary care, they have that responsibility to take care of this population. So us, our residents, our medical students need to have that, first that thing in their heart that yes, we have to take that extra effort to take care of these patients. And, it's awesome if you get that opportunity to go and get that fellowship training, that's awesome. But even if you do not, you need to make that extra effort to learn about the geriatric care, the principles, and try to incorporate them in your day-to-day practice. Yes, I think I have.
Thank you so much, Dr. Bhandari.
Yeah.
Thank you so much for sharing your view, Dr. Bhandari. Ginny, would you like to introduce our next?
I would be very happy to introduce our final speaker for this evening. Our final panelist is Dr. Javette Orgain, who is a past president of the IAFP, a past president of the National Medical Association. She is a life member of the IAFP, which means means at least 2 of 3 things. I'll let you decide which ones. It means she is either A, age 70, B, has been a member for more than 25 years, and or C, is retired. So she has a ton of life experience. She is also, she also received 2 Lifetime Achievement Awards from 2 different organizations in 2023. So she's got a lot of experience, and she's also been one of our Academy's subject matter experts on issues of health equity, and implicit bias. So with that said, I'd like to welcome Dr. Javette Orgain.
Thank you, Jenny, and thank everyone for speaking so far. I'd like to pivot away from training, because as I saw the poll, the majority of us are out of practice for 3 years, and so we are probably practicing and have not done a geriatric fellowship. So I'd like to pivot, and Jenny, if you could bring back those 5 M's, because today I was hopeful that we would talk about those 5 M's in a little bit more detail, because the next webinar is going to deal a lot with training. So Jenny, if you can bring up those 5 M's again. What I want to do most is the mind and what matters most, because I think that I'd like to share my experience, because she's right. I am in that geriatric age group. And I participate at Rush in a minority aging research study. We know statistically that African Americans, in terms of health equity, African Americans are 2 times more likely, and Hispanics are 1.5 times more likely to have issues with mentation and dementia, and depression. And the other piece is the 5 most common, and I know that we all know this, but just because a number of us may not have gone through a fellowship, the 5 most common in terms of the mind are Alzheimer's, vascular Lewy body, frontotemporal, and mixed dementias. And we oftentimes don't think about the mixed dementias when we're treating our patients in the clinic. And I wanted to bring that forward so that we could talk about that a little bit more. And additionally, the issue is, we're treating our patients in the lifespan. We're seeing them many of us may be delivering, and we're seeing them along that trajectory of life. Are we doing our due diligence with talking to them about advanced directives? What matters most? Is that recorded on the chart in your office? Have you had that discussion in terms of advanced directives? What do you want in life? What are you doing in your home to get prepared for the aging? What are you doing in regards to your medication and letting your family know what's going on with you? And I think that we as family physicians must do a better job of that in regards to advanced directives and that planning. I need to just say that I'm also a hospice physician, and I'm on the board for an institutional special needs plan, and I'm speaking for myself this evening, but I think that those are some of the things that we have to do. We know, and you all can verify this for me, for those of you who are trained, that there is a change in mentation as much as 10 years before the patient gets a diagnosis. And so when we're dealing with those common dementias, then we need to be looking at that. We need to be talking to our patients. We need to be doing those things that help them, particularly in relationships to what matters most and the medication. The deprescribing is a challenge for most of our patients, because they have chronic medical conditions, multiple chronic medical conditions, and they are afraid to make those changes, excuse me, in regards to the medications that they take. And it's not easy. And with that issue of the 5, 10, 20 medications that the patients are taking, we actually do not know about the interactions of all those medications and the benefit that they may be getting and the harm that some of them may be doing in regards to our patients. So I wanted to bring that to our attention in regards to come back to these 5 M's, and talk about what we need to do for our patients. We need to begin to look at them early on. We need to do those advanced directives and make sure that they do that advanced care planning. How many of your patients have a pulse or a MOST on their chart? How many have even considered DNRs? What is their end of life planning? How are they planning for their years as in that geriatric age group? And I think that those are some of the things that we need to talk about. I treat patients in the nursing home and many of those patients, the amount of medications is astronomical. And what we need to look at, many of them also are receiving thyroid medication and not being followed. We know that mentation can be impacted by thyroid hormone imbalance, but everyone is prescribed thyroid medication without any follow-up, without any, and so we need to begin to think about the population where they're being treated. They're not just being treated in your clinics. They're being treated in nursing homes. And we need to talk about and address the nursing home population and the care that's not received in the nursing home. We know that President Biden and Vice President Kamala Harris are talking about the staffing and the pay that's required in nursing homes to improve the care of that geriatric population. We don't talk about the prison population. We know that that is a significant geriatric population, and we know that there are challenges with the care in that population. So I wanted to bring these to our attention so that we as family physicians can begin to address some of those issues from an advocacy perspective. And that's what I wanted to say. I'm done.
Thank you so much, Dr. Orgain, for sharing all those insights with us. It was wonderful to hear about all those issues from you. Some of the population that, are the most vulnerable population, and we are not doing much, and we could do much more about, some of the population, and, just creating various tools, various programs, and just talking about these issues, I think would help us understand about these situations better.
Dr. Renji, you might see in the chat we have we have a couple of great comments about some of the barriers and challenges of providing older adult care, and then a medical student has dropped a question in the chat if you want to read it aloud, and leave it to our panelists to answer.
Sure, absolutely. So I'll start with the question from the medical student. Emmy has asked, "Hi everyone, I am a current medical student interested in geriatrics. Dr. Mantha mentions that geriatrics is a field with high job satisfaction. What do you all think accounts for this?" So I'd like to start with Dr. Mantha himself, and I think we could all answer and chime in on that.
Sure, yeah, that's a great question. To use a 5 M's, I think it's multifactorial. But so I think first of all that the work is meaningful, and I find this every day. I have the luxury of doing home visits with patients, which I will talk about more at our next talk. But I get 45 minutes to an hour, sometimes more, with the patient in their home, right? And so I'm able to actually go through all their medications, look at their gait, look at their home for the safety, look at their fall risk, talk about their goals of care. And I feel at the end of it that it is a meaningful dialogue, right? And I've made a difference. And I would say that the elderly population still is very grateful and really appreciative of the physician. I mean, these are not people who are going on Google or on TikTok looking stuff up, right? I mean, these are still people who are going to appreciate us and our relationship and trust in us, right? And if they feel like that we have their back, that they are going to actually trust in us. And so I would say that's what I've noticed. And how I would answer that. I feel that the work is fulfilling and that it matters.
Dr. Daisy, would you like to share your experience and the sense of fulfillment?
I could, but I actually want to hear from Dr. Orgain because she's got her hand up, and I want to hear what she says about this.
Sorry about that, Dr. Argan.
Not a problem. I'll share some additional experience because I love the geriatric population. I actually was a home health aide before going into medical school. I took care of a senior who was cantankerous, who lived alone, who was lonely, who was abandoned by her family. Did not know, because I had not gone into medical school, did not know that this would lead me down this path to love this area of medicine. So because I have done hospice and because I've done the geriatrics, it's absolutely rewarding because they need attention from us. They need us to guide their family in terms of the needs of that population. We can do so much in regards to educating the family about the needs of their elders, about their own personal needs, and how they themselves, as they move on into that age category, what they need to do for themselves. We can do so much education for them to have such a fulfilling end of life. And I think that that's what is so meaningful, that the information that we can impart that will help them along the way. And that's what I find so rewarding. And I love seniors. I love talking to them. I do better with seniors than I do with little people. Why don't you go, Emma? I appreciate you letting me go before you.
Yeah, no, well, I wanted to hear what you have to say, but I also wanted to respond a little bit to what you said earlier from the IAFP board, which was, I think, what you were saying about all the multimorbidity or multi-complexity of patients that you're seeing that are not being well managed. I think that is a huge, I think we all know that that's a huge problem in all aspects of medicine. Geriatrics just seeing more of it. And part of the problem is that unless you're in the VA, where it sounds like the system really is based more around patient care than around, a medical industrial complex, we're not getting paid to think, right? Like doctors, not just us, but like we're getting paid to do procedures. And this is where IAFP and our voices for advocacy are so meaningful. So I just want to encourage everyone to sign up for the advocacy opportunities through IAFP, because we need more thinkers out there in all fields of medicine, right? I mean, that shouldn't be happening.
Totally agree. Thank you.
Dr. Bhandari, do you have any thoughts about the question about job satisfaction in geriatrics?
So thank you, Dr. Mantha, for that question. So I think from my perspective, like I said, I'm not formally trained in geriatrics, but like I practice outpatient family care and academics. So I think if I have to say, caring for our geriatric population in our day-to-day primary care, yes, that gives me one of the, I would say, the greatest deal of satisfaction. I know it is complex. It is a challenge, especially in a primary care setting where we don't have the privilege of 45 minutes to deal with the patient. A lot of times we spend a lot time pre-charting the patients, trying to, spend time before the visit so we can know as much as possible about them, especially if they're new patients. But, and it could be, that their care is, we can't do everything in that one visit in the primary care, but having a, regular follow-up with them, and then over that time, developing that relationship which is so fulfilling. And as you develop that relationship with that patient, they kind of become like one of your like family. It becomes like a family, like you're treating somebody in your family like you could be treating your grandparents or some. So it is, I think it is, and not by any means saying I'm a full spectrum family physician, not by any means saying that any other part of family medicine is less rewarding or less fulfilling. But I think just because this is that vulnerable population that requires that in-depth care, understanding, and the time, I think once you start, taking care of them and they start seeing the benefit, and they start feeling that, yes, you really care for them. Yes, it is very, very meaningful and very satisfying for sure.
Personally, I feel like geriatrics is very rewarding for me, if I had to put in my 2 cents. First of all, I feel like geriatrics is the new frontier of medicine right now. There are so many things happening in geriatrics that we know nothing about, and there's so much more to learn about. The leading causes of death, the trend has slowly been changing. At the beginning of 20th century, it was mainly infectious. Then it became cardiovascular and cancer and so on. But we have better treatment for both cardiovascular as well as cancers. Most of the leading causes of death, morbidity now are related to aging. There are so many things about aging that we don't yet know, like, things like sarcopenia. Why does it happen? We just take it as, granted, it happens, basically. Osteoporosis. So many things that we haven't yet discovered. So many places where the guidelines fail, like completely fail, basically, primarily because guidelines were not developed for older patients. Like most of the studies did not take people over 90 years, into consideration. And also because most of the guidelines do not take multimorbidity into consideration. So there is so much more thinking that I could do that it makes my job much more fulfilling. And like Dr. Daisy said, I mean, and Dr. Mantha as well, we have more time, so we have more time to think about our patients, basically, and it's not just a procedure based. And we're thinking more. We are coming up with innovative ways to solve problems for our patients, and all of that is very, very rewarding. I would like to move on to the comments over here, comment section, and I may not do complete justice for all the comments, but I would just like to glean some of the information from here, and I would like to bring it to our panel's attention. One of the comments was with regards to great palliative care, like the lack of palliative care, the lack of individual remaining an individual, and families unwilling to allow geriatric care. How does the panel feel about that? Anyone?
I'll chime in. Because we need to do more in regards to education of the general population about family medicine and whole person care, then that also impacts how we interface with families with geriatric care. And so as a result, there is that disconnect between the lifespan and the spectrum. And so the time that we have to spend with our patients and our families, the requirement to spend 15 minutes, it's untenable. We need a change in our healthcare system, particularly for our geriatric patients. There is no way that we should even consider spending 15 minutes with our geriatric population. But needless to say, we are in a capitalist system. The insurance companies and the money are important to keep, your practice alive, but we are doing a disservice in regards to the care of our patients. For not just our geriatric patients. To say that we can spend 15 minutes, it's untenable. And somehow that needs to change. And I don't know how, but that's another advocacy point in regards to how we continue to practice medicine. So.
And I think at that point, thank you so much, Dr. Organ. And I think that point, to some extent, addresses the other comment that we have over here, where we have a comment about love advanced care planning, but doing it takes time and not having enough time. I think
Yeah.
this is one of the issues that all of us have as primary care providers. And I think if we move in a more organized way and talk about increasing time, spent with our patients, maybe we would reach somewhere. I think Dr. Organ and Dr. Daisy would have something more to share with this.
For those of you who are in positions of authority, in terms of scheduling and things of that nature, the difficulty is in terms of payment. If you only have that 15 minutes, you really need to bring that patient back more than every 3 months, in terms of care. And that makes it an issue of payment, okay? But you really do. It makes an issue of appointment availability, particularly now that we're really clear that we are decreasing the number of physicians who are in practice. It makes it a serious issue in regards to putting someone in your patient schedule because of that shortage of staff and shortage of physicians that are available. You all have told us about the lack that you have in Southern Illinois. So how do you therefore handle that burden? You get stressed out and your own well-being comes into question. And we don't want that to occur. So how do we, it's a challenge, needless to say. And I just say advocacy is going to be quite important.
If I could just sort of, answer that point from Jody just a little bit there. I think too, it's important to understand that advanced care planning doesn't have to be like a one-time thing, right? We oftentimes can revisit it. A patient who has a chronic life-limiting illness, who's got cancer, who has COPD, who has CHF, right? At first, they may not want to broach that conversation. They may want to be a full code. Then as things happen, as they get hospitalized, as they have a decline, then they may want to revisit that. And it's important for us to revisit it too, right? With each sort of change, like in the person's status, right? So it isn't actually like a one-off conversation that we're only doing one time. So that's what I would add to on that point.
We also need to provide them with the resources. 5 Wishes provides those booklets, 5 Wishes. There are a number, you can go to cdc.gov. The VA has a wealth of information in terms of how to handle those discussions, what questions, you don't have to reinvent the wheel. What questions are available that you can share with family members so that they can have those discussions with their loved ones. There's a wealth of resources that you don't have to reinvent the wheel. And I think one of my presentations, it was about 2 or 3 pages of resources. We can bring those back out again. So
I would say too that what I do and what I think you have to do, because we are all limited by time in our visits, even if it's like a little bit more, you have to uptrain your team and you have to have a team that can address these things for you. So I would love to do my own advanced directives. I think I do it better than anyone else in my clinic, but I don't have time. So I've uptrained my social workers to do it and they can do that discussion. And it took a while, but I don't have to pull my hair out that I can't do it in a 15, 30, whatever minute visit, because I just bring it up over and over again, and then I refer them to the social worker to actually do it. Same thing with like uptraining nurses. I think Dr. Grain is right. I mean, we have to have the resources for these folks, and we don't have the resources for these folks, but we have people on our teams that are smart and reliable, and we can start using them. The hardest thing for me is I don't know if homebound's the right word, but my elderly who are aging in place and don't have a support system, because I don't have anything I can do for them. And like that to me it's bigger than the medical system. You know, how do we support, you know, that's community. That's the fact that we are all living in isolation, and it's only been made worse by the pandemic. And what are we doing to address that? We're not. We're just becoming more and more polarized and hating each other more and staying in our own little worlds. And I had a discussion today with one of my geriatric patients and her son about trying to stay more socially engaged, and it's okay to get out more after COVID. And all they could come up with was phone, Zoom, TV. And even as I'm saying, you know, need to stay more socially engaged, need to stay more physically engaged, need to stay more mentally engaged, those were their solutions. And, you know, at least she has her son. You know, I've got patients who've got no relatives, nobody, a friend or a neighbor who takes them grocery shopping, and that's it.
I need to add some additional resources because I'm glad you said that, Emma. There is Mathers, Mathers, and if they're watching TV, then, and if they are connected in terms of internet, then Mathers has dancing, they have yoga, they have exercise for those seniors who are living alone and isolated. So I need to just add some of those additional resources because that's available. People are afraid to go out. People are afraid to venture. They're afraid to have the deliveries, but all of those things are available. And we just need to pull them together and let them know about them. And so I'll add some of those resources to the presentation.
I know we are getting a little bit past the hour. I just wanted to run through a couple of last minute announcements before we head on to our evening, and hopefully we'll see a lot of you back in a couple weeks just to fill you in on what is still on tap. We will be doing part 2 of this presentation, if I can get back to the slide. Part 2 is careers in caring for older adults. So we'll welcome back Dr. Ranjit and Dr. Mantha, along with Dr. Raj Shah, who's the co-chair of the member interest group, and also Dr. Deb Edberg and Dr. Jin Balick, who also have unique practice settings that consist largely of older adult patients. Some of the resources, and these will all be emailed to you, the 5 M's. The Brain Trust is IAFP's project that has all kinds of information about early detection of dementia. Dr. Ranjit and Dr. Raj Shah have been our leaders on that. Dr. Mantha and Dr. Daisy have participated in some of the podcasts. So these will all be sent to you. And then if you're looking for some self-study resources, both IAFP and the American Geriatrics Society have online self-study resources, and AGS does have also free student membership like IAFP. So that's a great way for current medical students to start exploring more into those topics. For those of you practicing physicians, the next Brain Trust webinar will be in February, February 21st, I believe. And this meets the CME licensing requirements for the state of Illinois for all physicians who see patients over age 26. And then just because Dr. Mantha practices in the VA system, this came across, I think I found it on Twitter. The Veterans Affairs is having a career open house virtual online. This is a great way to learn more and ask questions. So that will be also in your follow-up email. Some final things for your calendar: Essential Evidence Update CME Conference. We will have it in Naperville. It will be live. It will be in person. It's a great way to get so much of your bite-sized CME for the year. And we've set the date for our White Sox game. So it may be winter now. Spring training starts soon, and we will have our annual White Sox game on Friday, June 7th. And also Family Medicine Midwest is back. That's our annual regional conference that is showcasing the family medicine workforce. It's October in Wisconsin. There'll be much more coming on that. And then you'll be able to also help your academy by posting Google reviews. It actually helps other people find us, whether it's potential members or partner organizations. They can find us on Google, and those reviews actually help quite a bit. I'm going to stop sharing now. I see there's a couple more comments in the chat. I want to make sure we don't leave anyone out. All wonderful, positive things. So if our MIG leaders have anything else to add, we can wrap it up for the night and wish everyone a wonderful evening and hopefully see all of you and more on February 13th.
Thank you all. Have a good evening.
Thank you. Bye, everybody.
Thank you, everyone.
Bye, everyone.